Everybody to Pediatric Grand Rounds, and I am giving Glenn just a minute to get his food and come up and do the introductions. Here he is. Okay.
Thanks very much, Rafi, and thanks everyone for joining us, especially those of you on Zoom who couldn't be here in person. It's always, I think, a great pleasure for faculty to be able to introduce their former fellows as Grand Round speakers, and that's what we get today. Nicole Penwell, who's our speaker today, is currently works in Colorado, but she attended medical school and received her MPH at Boston University, and then was a resident at Children's Hospital Colorado. Subsequently, we were very fortunate to recruit her to our Pediatric Hospital Medicine Fellowship, which she completed in 2022, and then Denver got her back. She is now an assistant professor with the Children's Hospital Colorado section of hospital medicine. During her fellowship, certainly within our division, we were doing a lot of work on understanding mental health and somatic symptoms and related disorders. And Nicole really leaned into this. This was a personal academic interest of hers, and she really got deep in on her academic side. And so she has led the development of a somatic symptom and related disorder clinical pathway, which she's going to share with us today. She started that work here at UCSF during her fellowship and has continued to engage. She's also published on the quality of care and mental health boarding admissions. Certainly, we've all had the experience of patients who are waiting for placement at psychiatric facilities. And she's currently at Children's Colorado, the inpatient physician lead for their system-wide redesign of suicide and depression screening and response. So it's my great pleasure to welcome Dr. Penwell up.
All right. Hi, everyone. It's wonderful to be back for this lecture. It's been wonderful to see some familiar faces, and I'm looking forward to giving this talk today. It's something I feel really passionate about, and I hope that you find this to be a really valuable hour. All right, so getting started. So today's presentation, early recognition, consistent messaging, and functional rehabilitation, strategies for managing pediatric somatization. Kiati Brombaut from psychiatry and Glenn Rosenbluth from hospital medicine who have both been mentors of mine in this work and are going to participate in our Q&A. So I've included them here. We do not have any disclosures. The objectives of today's talk are introduce the UCSF somatic symptom and related disorder inpatient clinical pathway, review key strategies for managing somatic symptom and related disorders, otherwise known as functional disorders in the inpatient setting and beyond, and to explore sample scripts for explaining somatic symptom and related disorders to patients and families. Somatization, or the expression of psychological or emotional factors as physical symptoms, is very common in children. I've seen data to suggest 1 in 10 children experience somatization, but I predict it's much greater than that. Commonly, somatization presents as symptoms such as belly pain, headaches, musculoskeletal pain, or other non-specific symptoms such as fatigue, nausea, or faintness. I think it's really helpful to think of somatization as a spectrum or a continuum. So on one end, the way that we commonly see and experience somatization might include things like butterflies when we're nervous or headaches when we're stressed. But on the more extreme and severe end, when patients experience severe, persistent, and debilitating symptoms, this culminates in a somatic symptom disorder, characterized by excessive symptoms that result in distressing thoughts and emotions, and culminate in pervasive functional impairment, which we treat, which is commonly seen in the outpatient setting, and we definitely treat in the inpatient setting. And importantly, somatization and somatic symptom disorder may present in isolation, or they may co-occur in individuals with underlying medical disorders associated with structural dysfunction, bodily injury, or inflammation. For example, non-epileptiform seizures are more common in patients with comorbid epilepsy. I have seen data that suggests up to 20% of our annual healthcare spending is associated with patients presenting to care with somatic complaints. The data is not great; it's hard to quantify, but I thought that this was, interesting estimate. A source of confusion in diagnosing and managing patients with somatic symptom-related disorders is inconsistent terminology used between disciplines to describe these diagnoses. Terminology I have heard used includes psychogenic, functional disorder, primary pain disorder, amplified pain syndrome, visceral hyperalgesia, non-obstructive feeding intolerance, and disorders of brain-gut interaction. Formal DSM-5 terminology is somatic symptom and related disorders, and there are subdiagnoses that include somatic symptom disorder and functional neurologic symptom disorder, i.e. Conversion disorder, and then also illness anxiety disorder, which was previously hypochondriacism. Unfortunately, use of inconsistent terminology is problematic. When we use all these different terminologies, right, ultimately patients are hearing different messages from us, and this can impede we as providers speaking the same language and impede patients' progress in their rehabilitative treatment. I argue that using consistent terminology to our peers, patients, and families is really, really important, and that it really might help patients progress in their recovery. So for our presentation today, and I hope for your practice going forward, we're going to be using DSM-5 terminology. So, I usually try to avoid just reading from a slide, but I think that we as pediatric providers, many of us are not psychiatrists or psychologists and don't have a lot of experience really looking at the DSM-5 and reading the criteria. So I think it's important for us to see. So under that umbrella of somatic symptom and related disorders, first we have a subdiagnosis of somatic symptom disorder. So this diagnosis is defined as one or more somatic symptoms that are distressing or result in significant disruption of daily life. Excessive thoughts, feelings, or behaviors related to somatic symptoms or associated health concerns as manifested by at least one of the following: disproportionate and persistent thoughts about the serious of one's symptoms, persistently high levels of anxiety about health and symptoms, excessive time and energy devoted to these symptoms or health concerns, and persistent symptoms. One thing I really want to highlight in this definition is that the criteria in the DSM-5 really describes positive findings. So positive findings: disproportionate, excessive, disruption of daily life, rather than negative findings or the absence of other medical findings to explain the patient's symptoms. So this has been a big change in the DSM-5 as opposed to the DSM-4. There has been this intentional shift away from thinking of these disorders as a diagnosis of exclusion and having in their diagnostic criteria medically unexplained symptoms. This is really important. This needs to be reflected in our messaging to patients. And this is really important because in general, when patients hear that we just have not found an explanation for their symptoms, can very much sort of result in this fear of a misdiagnosis and a concern that we just haven't found the diagnosis. Another important subdiagnosis that we treat in the inpatient setting a lot is functional neurologic symptom disorder, still with the additional name of conversion disorder. The DSM-5 criteria are as follows: one or more symptoms of altered voluntary motor or sensory function. Clinical findings provide evidence of incompatibility between the symptoms and recognized neurologic or medical conditions. The symptom or deficit is not better explained by another medical or mental disorder. And finally, the symptoms or deficit causes clinically significant distress or impairment in social, occupational, and other important areas of functioning or warrants medical evaluation. So you will note here that in the DSM-5, under this subdiagnosis, there is still a clause of medically unexplained symptoms. In my experience, and I believe in the experience of my colleagues, both in the inpatient setting and the outpatient setting, there are a number of factors that make caring for patients with somatic symptom and related disorders really challenging, including a lack of standardization of care, an idea of mind-body dualism and mental health stigma. Only 50% of youth with mental health conditions receive appropriate treatment. Also, healthcare overutilization, including excessive diagnostic testing, overuse of medications with little benefit, and risk of iatrogenic interventions. Additionally, limited provider training in diagnosing, discussing, and managing somatic symptom-related disorders, resulting in provider discomfort, inconsistent messaging, poor patient and family trust, and limited or late psychiatry involvement. Additionally, challenges in patients and families accepting the diagnosis, and then delays in enacting an appropriate treatment plan. In 2019, the American Academy of Child and Adolescent Psychiatry sponsored a national working group of consultation liaison psychiatrists to develop a clinical pathway for inpatient management of SSRDs. Their clinical pathway and recommendations for standard of care are published. Nationally, I'm aware of 4 other institutions that have enacted clinical pathways for SSRDs at their institution, but there are likely a growing number. I know 3 of those I know have published on their work. Dr. Braumbach, we're very lucky to have, is one of the co-authors on this really important paper. This guideline really lays out a really nice framework of how suggestions for managing these patients in a stepwise fashion, and ultimately became the backbone for our clinical pathway. So what is a clinical pathway? For those less familiar, a clinical pathway is a point of care clinical decision-making tool used to guide providers in making evidence-based management decisions. They aim to translate guidelines or evidence into easy-to-use references, standardized clinical processes of care, and an institution can tailor their recommendations from a published guideline to the unique culture or environment of their hospital. In recent years, clinical pathways have been increasingly adopted, particularly in ED and inpatient settings, but a growing number are appearing in outpatient settings as well. Published studies of their use have demonstrated improvements in clinical outcomes, reductions in practice variation, and reductions in hospital resource utilization, including costs and length of stay. Unfortunately, there are few published examples for mental health conditions, but the number's growing. So at UCSF, we, during the COVID-19 pandemic, we sort of anecdotally on the inpatient floor felt that we were experiencing a large increase in number of patients admitted with somatic symptom and related disorders. Admittedly, we didn't tend to call it that, right, which is an area for nationally for improvement in terms of terminology. But in that context, we, as a division, really wanted to improve the care that we were providing these patients. And so we sought out to develop our own somatic symptom and related disorder clinical pathway. The objectives of our pathway were to standardize our approach to the way we were diagnosing patients, and how and who we were involving in their care in terms of subspecialists, most notably psychiatry as an improvement, and also improve our messaging to patients and families utilizing the DSM-5 terminology, to promote prioritization of functional recovery, to develop multi-pronged rehabilitative treatment plans, and to provide patients and families high-quality educational tools. So in 2021, we convened a multidisciplinary stakeholder team. Ultimately, I conducted 15 one-on-one interviews with each member of our multidisciplinary team. Additionally, conducted chart review and utilized lean methodology, notably value stream mapping, to identify problem areas, and brainstorm areas for improvement. We produced a pathway document. We're gonna have a QR code later on in the presentation to direct you to where you can access this when you're doing patient care. But the document includes a flow chart, which you see on the right. No expectation to read the font. It's like size 2 at the moment. But just to show you what it vaguely looks like, And then additionally, the document includes appendices, which includes a step-by-step guide with evidence and rationale, sample communication and educational like scripts that you can use with patients and families, and then additional resources for patients and families. So, sharing, ultimately, I really want to walk you through the steps of this framework. I think they're really helpful. And while this guideline was specifically directed towards inpatient providers, I think that these steps are still very applicable to the outpatient setting. So the first step is that we need to early on, explicitly consider whether or not we are worried about a somatic symptom and related disorder. Somatization should be considered when there are inconsistencies in the history or physical exam, when the preceding medical workup has been inconclusive, and if there has been a history of psychosocial stressors, poor functioning, or coping skills. The next step is it can be really important to outline goals and expectations with a patient and family. In the inpatient setting, I strongly recommend that, talking about walking patients through these steps, describing that the first thing that you're going to do is do a very dedicated effort to compile a record of completed diagnostic testing. Next, you'll tell the family that you are going to complete a judicious medical workup. For the other care team members that you involve in the care, it's important that everyone develops a consensus about the diagnosis, and that in the hospital stay, we will aim to initiate a therapeutic treatment plan for continued recovery as an outpatient. It can be really important at the beginning to make sure we set expectations that we don't hope to cure a patient's symptoms while they're hospitalized, but that we initiate a plan for continued recovery as an outpatient. So with that in mind, early on, when you have a suspicion for a somatic symptom and related disorder, highlighting that we don't expect to resolve symptoms, but we do plan to develop a plan for this recovery. Here is a sample script that you could use in your care. We see many patients with symptoms similar to what your child has and have a standard multidisciplinary approach to care that includes different consultants from medical subspecialties, including gastroenterology, neurology, and psychiatry or psychology, physical and occupational therapy, and/or social work. This comprehensive approach will help us better understand your child's symptoms and their impact on his or their life. We will review the past medical workup in detail, consider whether any additional evaluations are needed. Once the workup is complete, we will hold a team meeting with providers and families to discuss our findings, and we will create a treatment plan to help your child achieve symptom relief over time and return to normal activities. Your child's symptoms may not be gone when your child is ready to leave the hospital. The next step in caring for these patients is the early interdisciplinary evaluation. That will take place in the first day to couple days of the patient's hospital stay. When early on you are beginning to consult subspecialists to help weigh in about the patient's diagnostic workup, depending, and those subspecialists, depending on what the presenting symptoms are, whether they're more apparent neurologic deficits or chronic abdominal pain, acute on chronic abdominal pain. In addition, we're in good practice of consulting neurology, gastroenterology, for example, but I encourage you to consult psychiatry early. And I think in the hospital medicine setting, we are most accustomed to, or our understanding often is that psychiatry, the available inpatient bandwidth is enough to do safety assessments and medication management. But in talking with psychiatry, they want to hear from us. They want to hear from us early. A common pattern is that when we've done a lot of workup, we're many days into this, then psychiatry may get consulted, and that late in the game addition to the care team sometimes can be counterproductive, right? At that point in time, patients have been hearing a lot of your tests are negative, your tests are negative. So now psychiatry is here, right? Which can have the tendency to create the message, it's all in your head, right? Which can undermine trust and it undermine patients and families accepting the diagnosis. Instead, psychiatry has vocalized, Dr. Brombaugh has said, we want to hear from our teams early. And a couple things, by involving patients early, there's a shift towards walking two paths, right? You can continue doing a diagnostic workup with gastroenterology or neurology, while psychiatry can also do their evaluation, right? When you talk to families about this, one way to introduce it, acknowledging we are really trying to validate their experience of their symptoms and highlight that they've been suffering a lot. They've had really intense symptoms. It's been very life disrupting, right? And so we also want psychiatry and psychology on our team to help support them through that very difficult process and experience, right? One important thing I've been told is that legally we do need to ask patients for permission for psychiatry to do an evaluation, which is an unfortunate, I think, mental health stigma, a challenge. But nonetheless, even if a family does not give permission for psychiatry to be involved early on, psychiatry also in the background can help be involved in the patient's care, discussing the case with the other involved team members and continuing that conversation, and may be able to provide suggestions too, if you have a high suspicion of somatic symptom and related disorder, of how to further sort of encourage the family to sort of welcome psychiatry involved in their care. The other thing I would really encourage you to do, whether this is in the inpatient setting or the outpatient setting, spend the time to get a really good record of what the diagnostic testing has been to date. It's time intensive. It's hard to do that. It's hard to get records, but in the long run, you might really save yourself some time. Additionally, one thing in the hospital setting can be very challenging is that we see patients for potentially a short period of time. We don't have a history necessarily of having built trust and rapport with them, as is usually a little bit more of a luxury in the outpatient setting. And so if you really do your homework, demonstrating that to the family, really saying, I understand that you've had this test, this test, this test, that really demonstrates attentiveness to their special case and can be very impactful in terms of building trust. Also, in the inpatient setting, I mentioned we get to know whether you're a consultant, a hospitalist, we get to know these patients in a short period of time. Utilize the providers, both the PCP, outpatient subspecialists, mental health providers who know this patient well. If you can connect with them, including in front and with the family, that can really help build quick rapport and knowing, and you want to start that communication with outpatient providers. We'll talk more about that later. You will want to conduct a thorough but judicious medical workup. By having done your homework, we will really aim to avoid repeating diagnostic tests that have already been done that would further medicalize this patient. And so we're really looking for gaps that we really need to that diagnostic information to make sure that we are clear about the diagnosis. The guideline also recommends placing functional plan disorders. These are orders that might help promote structure and routine in the inpatient setting. I have more on that in the next slide. And then also it's strongly recommended that we organize an interdisciplinary provider meeting. If a patient you anticipate may only stay for a short period of time, I think sometimes logistically that can be challenging, but if you have a sense that this is a patient who may stay in the hospital for upwards of several days, on day one, if you can try to work towards sending that group email that gets people into a conference room 3 days in advance, that can always be canceled, but can be a very helpful thing to try to do up front, anticipating that that might be needed. So functional plan orders, we don't have an order set for this. Hopefully, maybe sometime in the future we will. But in the meantime, these are orders that one can order as nursing communication orders, including establishing a sleep-wake cycle with bedtimes and wake up times, being out of bed for every meal, a minimal daily ambulation goal, if available, encouraging non-pharmacologic and integrative medicine techniques like deep breathing and meditation. And if PT and OT, for example, have been involved in the patient's care, trying to reinforce their suggested daily activity plan. We will talk about, and then homework. All of these things are trying to make an effort to promote normal daily functioning. Again, all of these things can happen concurrently when you are also completing a judicious medical workup. So the next step is an interdisciplinary provider meeting. Really importantly, I've mentioned that one of the real challenges in managing these patients is a lot of fragmentation about the diagnosis and about messaging. And so this meeting is really important in an effort to really get every medical provider involved in this patient's care on the same page, so that we can have consensus about the diagnosis and consensus about the appropriate messaging. So collectively, the involved providers, can review all of the diagnostic results and discuss their impressions. If the team collectively comes to the consensus that everyone feels that this is consistent with a somatic symptom or related disorder, I strongly encourage you to update the problem list. We notoriously, I think, always have our problem abdominal pain or, gait disturbance. But by updating it, refining it, changing it to a functional neurologic symptom disorder is going to be another opportunity to promote consistent messaging. Other providers, future providers, look at the problem list, right? This will be on the discharge summary, and also thanks to the Cures Act, families may see this, right? And it's again another opportunity for them to see the diagnosis. Next step for informing the family. Naturally, in the inpatient setting, this potentially works well as sort of a 30-minute provider meeting, a 30-minute family meeting right after. We try to include all of the consulting services there. Importantly, families may have questions that are best answered by different subspecialties. So it's nice, if possible, to have everyone there. When possible, to be able to have outpatient continuity providers on the phone or on Zoom, that can also be very helpful. Again, a provider that families know well and has a trust relationship with. Ultimately, you'll be presenting this diagnosis, again, trying to really use DSM-5 terminology. Some tips that can be really important as you deliver this diagnosis: continue to validate the patient's symptoms, clearly demonstrate that his or her symptoms are being taken seriously, demonstrate thoughtfulness to the patient's case by vocally reviewing their history of diagnostic results, and ultimately provide a clear, supportive, but matter-of-fact explanation of the diagnosis. This will also be your opportunity to begin to introduce the multi-pronged rehabilitative treatment plan, and that we'll talk to in a minute. This is a sample script. As we said at the beginning of your child's hospital stay, after all of the specialists have consulted and completed your child's medical workup, we come together as a multidisciplinary team to discuss what we have found to be contributing to your child's symptoms and what the evidence-based treatment is for the condition. We want to give you a chance to ask questions and to be sure that you feel comfortable about our assessment and treatment plan. We understand how distressing these symptoms have been and want to make sure we address your questions or concerns. We want to share you with a summary of your child's symptoms, why we consulted these specialists, what diagnoses we were considering, and what our findings did and did not support. Please tell us along the way if we have any part of the history wrong or if there's anything you do not understand. And please let us know if there's any particular medical condition or diagnosis that you feel we have not adequately addressed. Explaining somatic symptom and related disorders in families is both in a way that is both understandable and acceptable is frequently challenging. It's challenging for many of us. And I want to, in addition to some of those tips I just shared, I want to share some additional strategies that can be helpful. I mentioned that it's just really important to ensure that the patient and family feel that you have taken their case very seriously. Presenting those details, the details of their diagnostic workup, shows that you put in the time and were really thoughtful about their care. A primary reason that many patients and their parents feel angry and reject the diagnosis of a somatization disorder is that they feel disrespected and not believed. So you really want to avoid that. Importantly, as we sort of talked about at the beginning of this presentation, try to avoid focusing on negative findings, that test results came back negative or were normal. This may inadvertently result in patients and families feeling fearful of a misdiagnosis. So trying to emphasize that, like, we can see that your symptoms have caused a lot of suffering, have been very distressing, and have made it very hard to live, to be able to attend school and enjoy the hobbies that you really enjoy. So emphasizing again that disproportionate, excessive, positive features as well. Sometimes it can also be very helpful to use themes in everyday language that people can relate to. Again, sort of relating somatization to things like butterflies in the stomach or headaches that many of us get, or our heart beating rapidly when we're scared. So as we try to introduce what is somatization to families. Effective messaging has prognostic impact. In a retrospective cohort of 60 patients with somatic disorders by So et al., patients and families who fully accepted the diagnosis demonstrated nearly a 20-fold greater complete recovery rate and a significantly lower readmission rate. So really putting the emphasis on how important our messaging is. The next few slides are some sample scripts that you might adopt in your practice of how to explain somatic symptom and related disorders, because it can be tricky. This one, when children experience severe physical symptoms that interfere with their daily life, such as headaches, stomach aches, or muscle aches, we consider both structural conditions that may result from bodily injury or inflammation, and functional somatic symptom disorders, which occur when parts of the body and the brain miscommunicate. Everybody's body has a different way of showing and responding to stress and emotion. In a stressful situation, one person might get a headache due to feeling overwhelmed, while another person might faint. Sometimes stress and emotional experiences are so private they get bottled up inside without the person recognizing their own stress. Here, the body does the talking for them through physical symptoms. Somatization can happen alongside many different medical conditions. For example, a teen with epilepsy has seizures due to an electrical misfiring in the brain that sends signals to the body. The pathway used for epileptic seizures is familiar to the body and can become the same pathway that stress and emotions are expressed, producing non-epileptic stress seizures. Expressing emotions and stress by familiar pathways can also happen with migraines or with broken bones that have healed, or a lot of other medical conditions. Sometimes it also can be helpful to use metaphors to differentiate somatic symptom disorders from other types of bodily structural dysfunction, bodily injury, or inflammation. I like the software versus hardware metaphor. Let's say you're watching YouTube videos online and all of a sudden the video freezes and won't load. Is it a computer problem? A problem with the physical hardware of the computer? This would be a structural problem. Alternatively, it may very well be an internet problem, a problem with how two computers are sending messages to each other, or a functional problem. This requires a different type of fix. An example is a common headache. An MRI picture of the brain could appear normal, suggesting no structural injury to the brain, but the pain may be severe. Clearly, there's a problem. Something about the brain isn't functioning appropriately. While medication sometimes helps headaches, good sleep, hydration, and managing our stress are key to treating and preventing headaches, a different type of fix. If anyone else has any explanations or metaphors they love, I welcome additions.
I just have a question. Nowhere have I seen you mention cultural aspects. I mean, things like, for instance, you were talking earlier about mental health stigma. My understanding that's tremendously cultural. You know, some cultures, some parts of the country, you know, every kid's in therapy from age 5, whereas other cultures, and cultures and so forth, there's a huge stigma, as you pointed out. How do you incorporate that in your whole schema?
Thank you. So the question was about, how should we think about cultural factors that might inform things like mental health stigma and accessing mental health care that might inform patients presenting with somatic symptom disorders. I previously had a slide in here to sort of describe and demonstrate that our understanding of somatic symptom related disorders is that they are really complex. There are a lot of factors that contribute to patients developing these disorders, both cultural factors, genetic factors, early life experience and stresses, and it can be very complex. There is some older data at times to suggest correlations too with early childhood trauma, but there are also, in many, many cases, there are not clearly identifiable stressors. But I think, with every patient, even beyond this talk, there is a critical need for us to be thinking about mental health and, initiating that conversation with families. And, particularly if you get the sense that this is not something the family has thought about before, or it's culturally maybe, different cultures having different approaches to mental health care and the way we think through it, yes, it's very critical for us as providers. So the last big step, of this care is to implement a functional rehabilitative treatment plan. So resolution of somatic symptom related disability is contingent on demedicalizing patients, including weaning off unnecessary medications, IV fluids, and alternative methods of nutrition such as NG feeds, and try to, important to shift our focus away from medications as the center point of a patient's symptom management. Instead, we really want to shift our focus towards prioritizing functional recovery over symptom resolution. And functional recovery and symptom resolution is a gradual process. It's not, particularly in the inpatient setting, it's not going to be fixed immediately. It's not going to be fixed in one outpatient visit. And so it's really important that we communicate that to families, that this is going to be a gradual process, but research shows that this can be a very successful process, but it is going to take time. I mentioned that early on in the patient's care in the inpatient setting, if you have had potential concern for a somatic symptom-related disorder, to enact structure and routine, such as through implementing functional plan orders early on. At this point in time, we want to be continuing to reinforce this in the inpatient setting, but hopefully we're not just starting now. Additionally, as we look towards home, we're really going to be trying to help the patient and family think about how we can enact structure and routine at home. There are 5 critical dimensions of healthy functioning, including mental health and wellness, nutrition, exercise, sleep, and school. And we want to try and talk through families in each of those dimensions of healthy functioning to see how we can come up with a plan to gradually work towards more active daily functioning. It can be really helpful to try and help with families' brains and with outpatient providers who are going to be seeing patients after the hospital stay to come up with specific, realistic, incremental goals with observable behaviors. Sometimes it can be helpful to come up with some sort of reward system to sort of, really congratulate patients on gradual improvements back towards daily functioning, such as eating well. I like to encourage patients to push themselves 20% past their symptoms in hopes that over time, that will just push the bar a little bit further. When we are thinking about discharging patients and transitioning to an outpatient setting, it can be really helpful to involve our outpatient providers again, as much as possible. This helps preserve continuity. And again, patients have trust, hopefully, with outpatient providers. Something we don't do a lot is connect. Sometimes we're pretty decent at connecting with primary care doctors, often approaching discharge. As much as that can be an ongoing conversation during the hospital stay is ideal. If patients have established mental health providers, really connecting with them is really ideal as well. Again, a great opportunity to continue messaging and make sure that that provider is on the same page about where we stand in terms of diagnosis and messaging. The last bullet here, British Columbia Children's Hospital is an international leader in pediatric somatization and have made really wonderful educational materials, both for healthcare professionals as well as families. They have a family handbook that's easily accessible on their website, and I have it in this presentation here. I highly encourage accessing that for your patients. Something we don't talk enough about in the healthcare setting is school integration. School is a huge part of the pinnacle, really, of children's daily structure and routine. However, in the hospital, we might connect with primary care doctors, but I think in my experience, it's been pretty rare that we connect directly with schools. However, that can be really helpful. I have heard or read about expert psychiatrists' recommendation that kids must go to school. They don't, as a stepping stone, they don't have to go to class. They could spend time in the nurse office, spend time in the library, spend time in a quiet area, but they must go as sort of a mandatory trying to institute structure. And in expert experience, typically with enacting that, kids typically go to class pretty soon after. And so that can be an important stepping stone. At minimum, we as healthcare providers can send a letter to schools that explain the patient's somatic symptom related disorder diagnosis and provide some suggestions or guidelines about how to manage patients' symptoms at school and how to better integrate them in with their peers, avoid alienation, and optimize functioning. There's some papers at the back that include a school template. They're also going to be included in the sort of email that comes out after this and in the wiki folder. So no need to reinvent the wheel. I strongly recommend that you take a look at this school template, both if you're an outpatient provider and an inpatient provider. If possible, while I would recommend the letter at minimum, ideally we should connect with the family or with the schools. In the process of coming up with the clinical pathway, I met with some of our representatives from the school program, and that really highlighted that I think often they're an underutilized resource in our hospital. Erin Henderson was wonderful when we met, and she really emphasized that with her expertise, with the school program's expertise, they can be a great resource in helping come up with the appropriate language and talking to appropriate language in communicating with schools about needed accommodations and a stepwise reintegration plan. Cognitive behavioral therapy is the most evidence-backed treatment for SSRDs. It can assist patients in overcoming internal conflicts and underlying stressors, re-examine their health beliefs and how their sick role affects their symptoms, such as time spent thinking about symptoms and how that might affect worsening them, or the expectation that eating is going to cause abdominal pain, for example. Additionally, CBT can be really helpful in terms of restructuring counterproductive thought patterns and helping build coping mechanisms. In some research, there's not a lot of research, but the research that I've seen, perhaps there's more than I realize, CBT has been associated with reductions in symptom severity, enhanced physical functioning, and reduced healthcare utilization. Family cognitive behavioral therapy additionally has been shown to be associated with higher rates of elimination of symptoms, lower levels of relapse, and overall improved functioning. This is a nice diagram that comes from the British Columbia Children's Hospital that can be another good way to sort of set expectations with families, highlighting that yes, while we would love for a patient to just be on the consistent path towards recovery, typically recovery for these patients, it is going to have its highs and lows. There are going to be flares of symptoms. And rather than, encouraging families and patients to not think of that as treatment failure, but to reflect on when symptoms have been better, what about what were they practicing? What were they doing that maybe helped symptoms be in better control, and trying to leverage that. So, inspiring some reflection. Despite these preceding slides that hopefully provide helpful strategies towards improving our quality of care and provider experience caring for these patients, I recognize there is a number of unresolved challenges. Lack of hospitalist continuity, limited time, both in the inpatient setting and in outpatient setting, inadequate inpatient and outpatient resources and clinics. That might include limited specialty clinics or therapists, physical therapists, occupational therapists not being specialized or super trained, like many of us, in somatic symptom and related disorders, limited chronic pain clinics, et cetera. PCP discomfort with somatic symptom related disorders, long wait lists for mental health care, community providers generally not being trained or experienced in SSRDs, and then outpatient resources being concentrated in our big metropolitan areas. And we care for a lot of patients that are from other more rural regions. With all of these challenges that I haven't solved today, I wanted to see if there's anyone, who in your experience have identified some helpful strategies to overcome these challenges. Well, I'll keep working at it, huh? So, some key recommendations to take away from today. Early identification of somatization through simultaneous evaluations by multiple medical disciplines, including psychiatry. Set patient and family expectations for the hospital stay early, including that you're going to do a thorough but judicious medical workup. You're going to have an interdisciplinary diagnostic evaluation, including psychiatry. We have a goal for symptom reduction, but not elimination if feasible, and that we're really going to strive to develop a rehabilitative treatment plan that will carry on beyond the hospital stay for continued recovery. Ensure an effective interdisciplinary communication with the patients and caregivers, including consistent messaging. Hold an interdisciplinary provider meeting and informed family meeting once the diagnostic assessment is complete. Introduce a multi-pronged structured rehabilitative treatment plan early during the hospital stay, and then collaborate with the patient's primary care provider and established outpatient providers to develop a successful rehabilitative treatment plan. Here are some really helpful resources. Listed there is the link to the UCSF somatic symptom and related disorder inpatient clinical pathway, as well as the QR code that will take you to the document. Next on the list is the guideline that I referenced that really provides this step-by-step framework for managing patients. So the guidelines for developing a clinical pathway, but provides this great framework for managing patients with somatic symptom and related disorders. And then both a professional handbook and a family handbook from the British Columbia Children's Hospital, as well as the last one is the American Academy of Child and Adolescent Psychiatry. They have a physically ill child resource center with a lot of valuable resources, again, for patient and family education that I recommend you check out. I wanted to acknowledge most notably Dr. Rosenbluth and Dr. Brombach for being my mentors through this work, and our multidisciplinary clinical pathway team. It's been wonderful to collaborate with everyone through this work. I'm happy to take any questions, and Dr. Brombach and Dr. Rosenbluth may join me if needed. Yeah. Yes.
Thanks for this presentation. This is such a challenge. When I was struck by one of the tips that you gave, which was to not talk about the test being negative or normal. And one of the things that we encounter when we're dealing with parents who are anxious, there's something really pathologically terrible going on. Wondering how you thread that needle about the language, like this, maybe give a specific example of how you reassure them that we actually have investigated this quite thoroughly and are, we don't think that there's any, it's hard to avoid those words like negative and normal. So I'm wondering if you have any more nuanced approach to that.
My gut instinct is, as you mentioned, it can be very effective to ask patients and families what they're worried about explicitly. If they, for example, they've had a family member or, someone they know affected by a particular diagnosis, to elicit that very specific concern and perhaps address that, yes, describing the negative exam result. I think, ultimately, not to say we won't entirely, discuss and acknowledge normal test results, but wanting to not make that the sole theme of our explanation of why we are suspicious about a somatic symptom-related disorder. Just really trying to shift away from a diagnosis of exclusion. This was negative, this was negative, this was negative. So we are worried about a somatic symptom-related disorder. Instead, trying to shift more towards the framework of these are all the diagnoses we've considered. This is the diagnostic testing that we did. This diagnostic testing did come back normal, pointing away from this. Additionally, we have considered a somatic symptom-related disorder. I'm noticing that your symptoms have been very distressing, right? And perhaps are beyond what we would have expected to see on endoscopy if instead this were IBD. In that, taking that all together, I think that the most effective treatment plan for you, that your symptoms best align with a somatic symptom-related disorder, and the most effective treatment is going to be one focusing on functional recovery and with gradual symptom resolution. That's my best attempt.
Just to build up on what you said, we often recommend saying things like imaging shows us that there is no lump, tumor, mass, like really thinking of the things that parents are often worried about that are going to have catastrophic effects, because that's often the worry that they're missing something really big and life-threatening, and to really describe what it's showing you is normal, like what normal means. Like tumor, so you can say there's no mass, there's nothing that's blocking anything, depending on what the test is. And then you might not be able to get away from normal, but to then make it very explicit, the cognitive dissonance that in a usual situation, a normal person. And right now it's landing as a concerning thing, because there is the what ifs, and then so what are we missing, and making that a very explicit conversation in saying, let's reframe these. These are good things in medicine. You're very good at picking up kind of bad, life-threatening things. And so these are the things we look for, and it's not that. So it's a little bit of like walking back the edge of something really cool going on. It's like having and then acknowledging that there are unknowns, and that is where the sort of walking the two paths analogy comes in. So we're not saying that like you're done thinking about any other possibilities. You're going to walk these two paths at the same time. Stress and anyways, the stress is present because you're dealing with really concerning.
Yes.
Thank you for that. That was really helpful. I have a question about the historical track record for not believing certain populations. I was wondering how you can kind of validate the patient to acknowledge that they're bringing in, knowing when to.
Yes, sorry, can you rephrase your question?
Yeah. How do you like navigate I guess, yeah, how do you navigate the like difficult conversations when you know that someone belongs to a group that has historically been disenfranchised? You know that they know that you think that they have like a somatic SSRD, but which is like, I guess, more the general public as something that like we don't believe you. How do you balance that tension and how do you name it in the exam room without being?
Yeah, I think importantly from the earliest moments of your conversations with these patients, we should validate for all patients, no matter what community they come from, that these are very authentic symptoms, right? This is not factitious. Patients are truly suffering, and we really need to, I think we have a bad tendency, bias in medicine to think of these patients as if it's factitious. It's not factitious, right? And so we have to make sure we have to check our bias about that, right? And so really focusing and remembering that these patients are suffering, yeah, just validating. And so I think, there, in terms of effective messaging and ultimately shifting towards treatment plan, yes, it will be very important to ask open-ended questions about their understanding of their symptoms or their experience or comfort with mental health care. Again, trying to be as open-minded as possible, but really making sure to validate your concern, validate your patient's symptoms in building trust.
Can I speak to that point?
Please.
One of the ways I approach that is through a lens of empowerment. So any interaction I'm trying to have with the patient or parent, I'm hoping to have them leave feeling just as empowered, ideally more empowered than when they first came in. And yes, as providers, we want to be able to handle is not the right word, but to have a quality interaction with somebody from a variety of different cultures or countries. And I think the lens of empowerment is helpful because I can provide a vision for where I want them to get to. And they can fill in the details of what does that look like for them, right? And then they can also fill in the details of, okay, what do we think are the pieces that are going to help you get there? Because in Western culture, we medicalize a lot of things, right? But SSRDs have been going on for millennia, right? It's just that cultures have different ways of handling these things, right? Maybe it was a shaman, maybe it was the matriarch of the village or these group of families, but like typically it was a group of people, right? It was multidisciplinary in a cultural and sociological sense. And so we're working in California, like we see it all the time that the state is basically failing its people across the board, right? Because Nicole and teams have done a huge amount of work to develop this pathway, but at the end of this pathway is a bottleneck, right? Our providers like me and others with outpatient clinics where the resources aren't in place to handle this deluge of people, right? And then if the resources are there, then the state is telling us, well, no, they live in a different county, so they can't work with the psychologist that's in your clinic. And so there's that challenge. And then when I've gotten 8 hours of sleep and I'm not feeling so cynical, then I'm like, well, how can I ultimately be helpful here in the moment, right? So as an example, one of my patients, profoundly depressed for years, and nothing helped this kid. Tons of different meds, different therapists, nothing helped. Shockingly, her pain got better. She just continued to be profoundly depressed. And so I would sneak her into pain clinic just to keep an eye on her and make sure she was okay. And ultimately, I saw her one time and she was dramatically better. I was like, what happened? She's like, oh, I just went to visit family in Mexico. I was like, well, how long has it been since you've done that? She's like, 6 years, 7 years. And I'm like, well, what happened? She's like, changing perspective. And in my head, I was like, positively yelling expletives, surprised. But ultimately, it was this village, it was this family that could do something that probably no amount of healthcare could really accomplish, right? So ultimately, we're counting on people to try to fill in the pieces. Sorry for talking.
Go ahead, Dr. Brompa.
I just want to build on what you said so eloquently. A lot of times these patients live on the intersection of mental health stigma, structural disenfranchisement, code resources, pretty political application in a big picture way. And the first step is honestly just naming the elephant. And it's to recognize that you want to acknowledge that there is this experience of disenfranchisement and that you want to keep that in mind as you're sharing it and what you're thinking, and then really eliciting in psychiatry, kind of think of it as eliciting the illness experience rather than the medical narrative. So it's like, when did your pain start? What was your pain like? It's really like, how did you feel like it? What has that done to your life? Like, how is it limiting what you want to do? And really joining them in the narrative of what their illness experience has been rather than the symptom history can start feeling that you're empathic and you're joining them where they're at. And then I don't know that I would suggest you all do it, but this is where involving mental health, what we do is sort of illness experience genogram. So we like look at across the family. And this brings the cultural question a little bit. Like, what is your cultural experience across the family of illness? Like, how does this impact you? And when you pull all of these elements together, it kind of it's in that approach that patients will feel like you're kind of meeting them back, even if you're not giving them like a fix to make this go away.
Awesome. Thank you, everyone. We're at 1, but if there's any lingering questions, we can stay around for a few more minutes, and we are available by email too. Thank you very much for coming.
I want to give a huge thanks to Dr. Penwell for